Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Today, we're revisiting IgG4-Related disease, an enigmatic multi-organ condition that has evolved from a diagnostic challenge now to a therapeutic frontier. On this podcast, we first discussed IgG4-related disease with Dr. John Stone in January of 2024. This was a really great episode where Dr. Stone covered the history of this complex disorder. At the time, he hinted about potential new treatments being developed for this disease, though he couldn't discuss much because the clinical trial was still ongoing and the data was not publicly available. Now, the year is 2025, and the IgG4 treatment landscape is looking much different. We've invited Dr. Matthew Baker to give us an update on emerging treatments for IgG4-related disease. We discussed the role of B and T cells in disease pathogenesis, the limitations of traditional steroid therapy, the off-label use of rituximab, and most excitingly, the promising results of the Mitigate trial using inebilizumab, a CD19 targeting agent that may soon become the first FDA-approved drug to treat IgG4-related disease. We also touch on other therapies that didn't pan out, like abatacept, as well as newer strategies on the horizon, including obexelimab, BTK inhibitors, and even the potential role of IL-4 inhibition with dupilumab. Dr. Matthew Baker is the Associate Division Chief in the Division of Immunology and Rheumatology at Stanford University. He received his bachelor's degree from Pomona College, his medical degree from Harvard Medical School, and his master's degree in epidemiology and clinical research from Stanford University. He completed his internal medicine residency program at the Massachusetts General Hospital and his rheumatology fellowship at Stanford. Dr. Baker leads a robust clinical research program that bridges bench-to-bedside science with clinical trials as well as epidemiological studies. He focuses his work on IgG4-related disease, sarcoid, Sjogren's, and rheumatoid arthritis. Enjoy. Matt, welcome to the show.
Hi, John. Thanks for having me.
So we're going to be talking about IgG4-related disease. We had an awesome episode with Dr. Joan Stone about a year ago, and we wanted to update that because it seems like there's going to be a lot of emerging therapeutics that hopefully will get FDA approval within the next few months. And so we wanted to have somebody here to talk a little bit more, focusing on the medications that may be coming out pretty soon for our IgG4-related disease. Before we get there, can you tell us a little bit more about your understanding of what IgG4-related disease actually is?
Yeah. Well, again, thanks. It's great to be here. It's a really exciting time in IgG4-related disease. There's so much happening. In terms of what the disease is, I would say that's the area we've made the less progress on in terms compared to where we are with treatment advances, but there are a lot of great people working on it. We still generally consider it a disease that causes these mass-like lesions, and we characterize it as fibroinflammatory, meaning that the components that make up those masses are partially fibrotic or scar tissue, and partially inflammatory with immune cell infiltrates, mostly B cells and T cells. We still don't know really the inciting factor, the origin of the disease. There have been scant genetic studies. One nice GWAS studies did show some susceptibility loci in a couple genes like HLA-DRB1 and FC gamma receptor 2B. But we don't know the exact contribution of genetics to the disease. And we also don't know at this point if it's autoimmune or simply immune mediated. Certainly there's an aberrant immune response that's driving this, but we don't know what the trigger is. Is it an autoantigen? We haven't identified an autoantibody. And interestingly, the prevalence appears to be higher in men than women across a number of cohorts, as well as the Mitigate trial, which we'll talk about later. which studied inebilizumab, where we just sort of routinely see about a 1 to 5 to 1, 1.5 to 1 or 2 to 1 male to female predominance of this disease, which is obviously counter to most of the autoimmune diseases we're familiar with in rheumatology. So the exact significance of that remains unknown, but it may argue that this is more immune mediated than autoimmune.
And so, what actually happens in the disease? How do people actually get sick from IgG4 related disease? How does it affect their bodies?
Yeah, I mean, the first thing to consider is just how heterogeneous the disease is. So when you talk about one patient to another, it could be a totally different, presentation, and their story and their journey might be look very different. So because it can affect virtually any organ in the body, some patients have masses that are evident just at looking at them, in their salivary glands or their lacrimal glands, and that may be brought to attention much sooner, and they see an ENT or an ophthalmologist and get a workup done, often out of concern for malignancy like lymphoma or something else. It doesn't always mean that they get a diagnosis at that time. Sometimes, depending on where they're being seen and the familiarity with the disease, they may just be told, well, it doesn't look malignant, but we don't really have an answer. And those patients still struggle to find a home until they end up perhaps with a specialist who has some experience. And then other patients will present with much more acute, urgent manifestations in the pancreas, sometimes leading to obstruction and pain, but often just damage over time that leads to new onset diabetes or exocrine dysfunction and weight loss. We often will see patients who have been struggling for a year or two and have lost, sometimes 60 to 80 pounds without a clear reason. Or even more urgent manifestations, bile duct obstructions, retroperitoneal fibrosis that obstructs the ureters. And those, of course, get brought to attention relatively quickly. So patients can really present across a variety of different ways, and they unfortunately often sort of bounce around from providers and specialists, and it can sometimes take months or years to make the diagnosis.
Got it. So it sounds like, masses, whether, you could see them visually or upon imaging, and then these infiltrating lesions in various different organs that can affect the flow of bile, pancreas. It can damage the pancreas, damage the ureters from retroperitoneal fibrosis. Before this was recognized, what would happen to these patients over time?
Yeah, so some patients would get treated with steroids based on, for instance, the biopsies that showed sort of ruling out malignancy, showing inflammatory infiltrates. And, it is a very steroid responsive disease. So they would see improvement, but then after a short course, it typically would come back. And so unfortunately, patients would ultimately have just progressive organ damage. It's not uncommon for me to see patients who present with maybe today they're having salivary gland disease, and when we image cross-sectionally, we see a very atrophic pancreas, and it was likely that the pancreas had been involved years earlier and was already now just very damaged. That's unfortunately not uncommon. The other, issue is when patients present with masses and there's a significant concern for malignancy, they may undergo necessary surgeries or procedures. So previously, much before there was the awareness we have today, the pancreas had masses. Those patients would often undergo, very large Whipple procedures because of the concern for pancreatic adenocarcinoma. And then on pathology, they would see that it wasn't that at all, but it's a little bit too late at that point. The surgery is done. And so now I think given the recognition and awareness, there's much more sampling done ahead of time through ERCP and other measures to ensure that it's not this disease before undergoing such a surgery.
Awesome. So you mentioned that steroids seem to be very effective for IgG4, and yet you also mentioned that patients have relapse. So is it that, once you taper off the steroids, then the disease comes back?
We have some nice data initially, actually just looking at the pancreas patients. So the interesting thing about this disease is, it's obviously existed forever, but for many decades, each manifestation was sort of thought to be its own thing in isolation. So what used to be called type 1 autoimmune pancreatitis is what we now know is IgG4-related disease in the pancreas. But there are nice data from what the older studies in type 1 AIP, where you see if you induce remission with steroids, usually somewhere between a half a mg per kg and a mg per kg, and give that for a month and taper off usually over a couple months. Almost all the patients will go into remission, but if you then watch them off treatment, by a year, 50% will relapse, and by 3 years, 92% will relapse. And so
Holy moly.
it's quite uncommon to see a truly durable response just from steroids. They work well, but they don't provide long-term benefit. And of course, all the side effects and toxicities we worry about.
Right, right. So then what was tried? I imagine sort of some various types of DMARDs were attempted to try to get this under better controlled as a steroid-sparing agents, right?
Yeah, exactly. So I think, initially there's a lot of just anecdotal reports looking at, case series and just people's experience using things like azathioprine was relatively common, methotrexate, and probably mycophenolate would be the most common. Unfortunately, we have limited prospective randomized data and almost no head-to-head data of these steroid-sparing DMARDs. There's one meta-analysis of 15 studies, about 1,200 patients, that looked at patients who just got glucocorticoids compared with some steroid-sparing agent and glucocorticoids. And it did demonstrate across all those studies a reduction in relapse rate, a reduction, I think, by about 60% if you had this addition of a steroid-sparing agent. I think in my experience and talking to a lot of other experts who treat the disease commonly, we see a fair amount of relapse in these patients who are just maintained on something like azathioprine and methotrexate. And it's also unclear if that's enough to prevent progression perhaps into other organs or manifestations in the body. We don't have data on that, but I have seen that happen where a patient seems to be controlled, but then, later on they've developed a new area of involvement. And so I think for that reason, the envelope got pushed into other methods like B-cell depletion.
Yeah, talk to me a little bit about that, sort of when and how that came about of trying biologics such as, rituximab for.
Yeah, I mean, I think it harkens back a bit to, the little we know about pathogenesis, which is we believe that B cells and T cells play critical roles. We see B cell hyperactivity in patients, both in the periphery with increased plasmablasts, which are, the CD19 positive cells that are sort of represent the active B cell immune response in the moment, and then also elevated serum IgG4 in roughly 80% of patients and often very elevated, as well as IgE. So we know that the B cells are hyperactive. And then in the tissue as well, we see B cells and T cells. This dense lymphoplasmacytic infiltrate is both T cells and the plasma cells, which are mostly IgG4. And so much of this work has come out of MGH and a number of labs in Japan and elsewhere that have nicely demonstrated that these B cells are activated and probably presenting antigen to several different T cell subsets. One in particular, the type 2 follicular helper T cells, and those cells are known to produce cytokines like IL-4 and IL-13, which directly lead to class switching to IgG4 and IgE, which makes a lot of sense. Also, groups have shown an elevation in this subset of T cells called CD4 cytotoxic T cells. So normally we think of cytotoxic T cells as being CD8. The CD4 version has been described in other disease states like chronic infection with HIV or HCV. It's also been seen in other autoimmune or rheumatic diseases, even things like RA. But they seem to be particularly elevated in IgG4-related disease and in the tissue. And they produce pro-inflammatory cytokines like interferon gamma and IL-1 beta, pro-fibrotic cytokines like TGF-beta, and then they also produce perforin and granzymes, which leads to cell apoptosis and tissue destruction. So we think all those things kind of come together to really form these lesions. And so having made those observations, it made sense to target the B cells. And even with just a few patients, it became clear dramatic responses to the size of these lesions and to, significant reductions in serum IgG4. And interestingly, even if you look in the tissue, there was a nice study just looking at a patient with a skin lesion pre and post rituximab, in addition to depleting the B cells, the T cells also significantly reduce, likely because the B cells are no longer there to present antigen and activate and stimulate them. And so that really kind of, I think, opened the door to this concept that targeting B cells is critical. And following that, there was a small open label study of rituximab and MGH, I think with 30 patients, which was, very positive, as much as you can say with a kind of an open label study with a somewhat subjective endpoint. But I think it's clear to all of us that it works quite well in these patients.
Got it. And just to clarify, it seems like, from my understanding and speaking with Dr. Stone on the previous episode, it was used to believe that IgG4 was like pathogenic, right? That it represented actually that was the causative issue for this disease. And now it no longer seems to be the case.
Yeah, I think the jury's still out.
Or is it?
Yeah, I mean, I would say we don't know. I think it's less likely that it's pathogenic that it is, but I still think it may play a role. It may be sort of an innocent bystander or an epiphenomenon. I mean, the interesting thing about the IgG4 molecule is that we consider it as an anti-inflammatory immunoglobulin. It undergoes this thing called Fab-arm exchange. So basically, two different IgG4s recombine, and now you no longer have a functionally monovalent antibody. You have essentially a bispecific antibody that's naturally formed. And when that happens, it's much less effective at cross-linking antigen, forming immune complexes. The FC portion becomes weaker for, activating ADCC for, cellular toxicity. It doesn't bind the activating complement receptors. So it seems to have this role to downregulate the immune response. And, we see that, for instance, in examples, the classic example is around allergies, like with how beekeepers become immune to bee venom. So as you're exposed to something like bee venom, you have this big response because you have IgE production, which binds mast cells and activates them, and you get histamine release and then the response that you see from a bee sting. But if you're chronically exposed to the bee venom, you develop a lot of IgG4, which essentially outcompetes the IgE and binds the bee venom and doesn't activate the mast cells. So it has this kind of anti-allergic, anti-inflammatory response. The flip side is that we do know there are a number of conditions where IgG4 is the pathogenic molecule. So pemphigus would be the classic autoimmune disease where, you have this response against desmoglein, which there are different forms of pemphigus. One is the IgG4 is thought to amount as a response to the black fly saliva, and other ones it might be a drug response. But regardless, it's an IgG4 molecule that binds desmoglein and interrupts that interaction and leads to the autoimmune disease. So, in this disease, there's no clear correlation between serum IgG4 levels and like disease severity. They tend to be higher in patients with, more organ involvement, multi-system disease. They do go down with treatment, and it often serves as a very good biomarker for when the disease may be coming back, but definitely not always. And, I always make the point that we typically do not treat just a serum IgG4 level, but it should definitely clue you in to go looking for any sign of disease activity if it's rising. But to answer your question, I would say we cannot say definitively if it's pathogenic or not.
That's super interesting. I never knew that about beekeepers or pemphigus, that it involved an IgG4 molecule. So I want to talk a little bit about sort of the current treatment paradigm. So let's say you see in your clinic a patient that has salivary gland involvement or perhaps retroperitoneal fibrosis. How are you going to think about sort of setting up a treatment plan for them? And what agents are you going to use?
Yeah, it's so personalized. So, the first thing I would say is if you meet a patient with salivary gland disease, that's easy to assess on exam, but for sure, at the initial visit, I will get cross-sectional imaging of the chest, abdomen, pelvis, because many times, we find additional sites of disease. It might be subtle, some peribronchiovascular thickening in the lungs or some hypodense lesions in the kidney without, any major effect on function. Other times, you may actually find something more significant. So I always do that, and that might change the conversation right there. If it's truly just, let's say, submandibular gland enlargement and the patient has no symptoms, it's not cosmetically bothering them. In that situation, you can make the argument that just watchful waiting is appropriate. If you were going to do that, I would get routine labs, every 3 months and see them still regularly, probably every 3 to 6 months at least, because you really want to be aware that it's not progressing into other organs or that that's getting worse. Many patients, though, will want to treat that because it just is it can be disfiguring or just, a little bit uncomfortable. Fortunately, the sickest symptoms related to glandular involvement in IgG4-related disease are typically not pronounced, not like Sjogren's disease, but they may be. And if they are, that would be another reason to treat. And so in that situation, again, if it's isolated there, it would be reasonable to actually just do a moderate and relatively short course of steroids, which will almost certainly, help significantly. And then watch, because some patients, after you stop it, can have a couple of years with no symptoms. Others, it really may come right back in 2-3 months. You'll be thinking about other agents, but there is no algorithm. I mean, that's just that scenario. The other scenario, like you said, with retroperitoneal fibrosis, I would immediately be thinking about moderate to high dose steroids with rituximab up front, and then tapering off steroids over, typically 2 to 3 months, and then monitoring pretty closely with the rituximab. In that regard, I would sort of frame that as how we frame some of our other diseases, which is really kind of induction and then maintenance. So that would be to induce remission with steroids and rituximab, and then we would be thinking about how to maintain that. And that can look different for every patient as well. So now we typically use rituximab longer term, and each patient is a little bit different. So some patients will respond really nicely to the rituximab, and we'll continue to monitor them if it's retroperitoneal fibrosis with imaging. And we generally then repeat the treatment in a more reactive fashion. So if you start to see perhaps laboratory changes, IgG4 going up, the imaging changing at all, we'll immediately repeat the treatment. But for any given patient, that could be 9 months, 12 months later. It could even be 2 years later. And then rarely, very rarely, a patient might need it every 6 months. But that interval for maintenance has not been established. So we really don't know, is there just an optimal interval that all patients should be on, or should we be tailoring it like I just outlined? So my approach, and I think many people's approach right now, is more of that personalized tailoring. And what I've found now, treating a couple hundred patients for 10 years, is that many of them, whatever you kind of establish as that patient's interval, it tends to follow that. So if you find that the disease is sort of coming back in a year and a half, and you repeat the treatment, it's probably going to do the same thing in a year and a half. And you kind of just get that cadence of treatment for that patient. The challenge is, and one of the unmet needs is understanding, are we, by being reactive as opposed to just a proactive, like every 6 or 9 month treatment, are we missing something? Is there some degree of subclinical disease progression, damage accrual that is hard to capture, hard to measure? That's definitely an area that a lot of us are interested in investigating.
Fascinating. So it seems like sort of the field has moved from, steroids plus or minus one of these other like oral DMARDs, and now pretty much maybe steroids if it's like mild disease, and steroids plus rituximab, thinking about inducing them and then maintaining remission with rituximab. You mentioned, unmet needs, and it sounds like, I believe rituximab is not FDA approved for the treatment of IgG4-related disease. So what other treatments are out there? And maybe you could talk a little bit about a study that you were recently involved in that showed actually pretty good efficacy with a novel agent to treat IgG4-related disease.
Yeah, definitely. Like we said, it's a super exciting time. We've actually been sites now for 4 studies. So the one that you're mentioning here is inebilizumab, which was the Mitigate trial, which is incredibly exciting because we know the results of the randomized control portion, which was a year, and they were very positive. And what's great, so inebilizumab is a fully humanized antibody, and it's afucosylated. and it binds CD19. So those are all features that are different than rituximab, which is chimeric and not afucosylated and targets CD20. Some of the reasons why those distinctions are interesting and important. So the afucosylated portion. So there have been studies in neuromyelitis optica spectrum disorder and NMOSD with inebilizumab, and also previously with rituximab. It turns out that there's the receptor that's important on natural killer cells for ADCC is something called Fc gamma R3A. And there's a couple different genotypes. There's the FF genotype. So there's this F158 allele and V158 allele. And if you have the F158, there was a nice study that of 100 patients with NMOSD that got rituximab, and it showed those patients had a 5.5 times increased risk of relapse compared to those with the V158 allele. And that's because those patients' NK cells just aren't activated as well by the rituximab molecule. And so what the inebilizumab through this afucosylation process, that it increases the affinity for that receptor by tenfold and should help ameliorate that issue. And in fact, a recent paper came out looking at a number of patients treated with inebilizumab for NMOSD and showed that it didn't matter if you had either genotype, they all responded equally. So that's one interesting feature. The other, it's fully humanized, so hopefully improvements with drug reactions, things like that. And then the CD19 target is different too. So when we think about the spectrum of B cells, CD20 is a little more narrowly expressed on B cells. So you're not getting the same breadth of depletion as you do with CD19, which also targets plasmablasts and subsets of plasma cells and pre-B cells. And I think probably most importantly for IgG4-related disease would be the plasmablasts, which we know from studies are elevated in this disease and probably play a role.
Right. So from that standpoint, it sounds like maybe a better target because, while the rituximab can target those B cells, which is sort of come before the plasmablast, this one targets the B cells and the plasmablasts as well. So it may be maybe more potent immunosuppression.
Yeah, and so of course we don't have any head-to-head data, but the Mitigate trial was really a landmark study. It's the first registrational trial in IgG4-related disease and the first phase 3 randomized double-blind placebo-controlled trial where we have data. We had, I think, 135 patients. So 68 got inebilizumab, 67 got placebo. And it was administered IV similar to the dosing of rituximab. So day 1, day 15, week 26. So all patients were essentially had active disease and then were put into remission with steroids over the screening period. And so at day 1 or baseline, patients were on 20 milligrams of prednisone in remission and then were randomized to either inebilizumab or placebo. And the steroids were then tapered off in a protocolized way over 8 weeks. And then it's a clean endpoint. It's essentially just now we just follow everyone and see who flares and when. So there's, little concern for dropout or missing data, anything like that just contributes to essentially the endpoint. And it turned out there was an 87% reduction in the risk of flare if you were treated versus placebo. So really pretty profound results. And, it also reduced all the secondary endpoints with high statistical significance. So annualized flare rate, the ability to achieve remission off any sort of other treatment or steroid, cumulative steroid exposure was significantly reduced. So, very successful study and safety data, very small number for a year. It's hard to say much about safety, but there was nothing sort of new that came out. There was, some COVID, some lymphopenia, some urinary tract infections, but no new or concerning safety signals, no fatalities in that study. So.
Got it. And it sounds like based on that, the company is moving ahead to try to get FDA approval for this drug to treat IgG4-related disease as being sort of the first FDA-approved medication for this disorder.
Yeah, and that's critical because as you mentioned, we've been using rituximab and it's not FDA approved. We're completely using that off-label. And even with the biosimilars, there are patients where I cannot get it approved. And it's just, fortunately for us, we have we've had a number of active trials, and in those patients, I've actually been able to mostly get into studies, but they are really left with not much when they have severe disease, and insurance will not cover rituximab. Fortunately, like I said, with the biosimilars, we are able to get it approved most of the time now. But I think having something that's gone through this rigor and is FDA approved should help with having access to this for our patients.
So you mentioned the study, they received drug, at sort of the study onset and then at 6 months.
So then we followed them through 52 weeks. And then, there's an open label extension for this study that will go 3 years, which will be really nice. At that point, everyone, will obviously be on the treatment. So we'll accrue a lot more longer term patient safety data and efficacy as well. So, but you raise another interesting point, which is, this is very protocolized to give treatment every 6 months. So the RCP, the randomized portion, and the open label extension, all patients are going to be dosed every 6 months throughout that whole time. So what we're going to take away from this is like that, that works very well. But in our own practice, is that what we're going to do? Or are we going to sort of adopt this more to how we use rituximab currently? And I think, we don't know the answer to that. We know that this works, certainly compared to placebo. But is it necessary to deplete so frequently? We need to figure that out.
Awesome. So, based on historical data on rituximab, small trials, and now inebilizumab, with this large randomized controlled trial, it sounds like B-cell depleting therapies are very effective for the treatment of IgG4-related disease. Talk to me a little bit about other strategies that are not B-cell dependent or not primarily targeting B-cells that are either in clinical trials or that you think, could be tried for IgG4-related disease.
Yeah, I think so. Unfortunately, the other studies that have tried to target things like T-cell or T-cell interactions, for instance, have been a little bit disappointing. However, they've also been very small, and there aren't many. So one, there was a study with abatacept, which enrolled 10 patients at MGH with active disease, and it was open label. They were all treated, with standard 125 milligrams sub-Q weekly for 24 weeks. I think 3 out of 10 had what was called a complete response at the end, and about half had some form of response, but I don't think it was kind of overwhelmingly positive to the point where there's a lot of interest moving forward with that. As everyone knows, abatacept, is really involved in T-cell co-stimulation. So the idea there was, if we think these CD4 CTLs or the T follicular helper cells are really important, maybe if we can downregulate their activity specifically, that might be the pathway to go after. But I think it certainly didn't show the same promise as B-cell depletion. And then there was another study, again, driven by the group at MGH, John Stone and others, looking at elotuzumab, which was a really interesting idea because those CD4 CTLs that I described, they seem to have high expression of a cell surface marker called SLAM-F7. And elotuzumab was a drug that had already been developed for treating multiple myeloma, which it turns out also expresses SLAM-F7. And so that's an antibody directed against SLAM-F7. And so it was an idea to target those cells specifically. I actually don't know any of the data other than what's publicly available on clinicaltrials.gov. But what I see is that, they had intended to enroll a much higher number, but it was terminated after 8 patients. So presumably due to some safety or efficacy issues. So I don't think from what I've heard, there's no plans to move forward with that. So those are the 2 main non-B-cell targeted therapies that have been looked at through more prospective means. But there are other B-cell methods that I think are worth mentioning that are non-depleting, because I think we're clearly going to have a really good depleting option approved. And then the question is, are there other options that may be efficacious that might have safety benefits or other, long-term usage benefits, et cetera. So the first one to mention is obexelimab, it's an antibody therapy that binds to CD19 as well. But instead of depleting, the FC portion is engineered to bind Fc gamma R2b, which is a negative regulator of B cells. And it's engineered to bind that with 400-fold affinity or something. So basically it binds the B cell and then it just tries to shut it down. And so in prior studies, there was one phase 2 open label study of 15 patients years ago with that drug at MGH. And, 80% had a really nice response. And based on that, and the drug's also been used in lupus and RA, we know that the B cell numbers actually do go down a little bit, like maybe I think by 40% or so. But within, 6 to 8 weeks of stopping the drug, they actually are back and detectable. So it's not totally clear what's happening. They're not being depleted probably, and the numbers rebound quickly. So if that is effective, that would be a really interesting option, because if a patient gets sick, if there's a new pandemic, you need a vaccine, you can always hold the drug, and you should have, functional B cells to help you. And so obexelimab is currently being studied. We're helping run that study now here as a big phase 3. So that'll be, I think we're another year or two away from knowing how that goes, but that's an exciting potential. And then the other two worth mentioning are BTK inhibitors, one with rilzabrutinib and then one with zanubrutinib, which is actually an investigator-initiated trial we're doing here with 10 patients. And so, again, BTK inhibitors won't deplete the B cells. The B cell numbers stay the same, but they do inhibit essentially signaling through the BCR. So those more active B cells that are, theoretically responding to the disease should be downregulated. And so if that's effective, that's another great option of a medicine that you can start and stop, and may have a different safety profile. And those studies actually are both completed enrollment, and we anticipate data quite soon. So it's, again, a really exciting time.
And then you mentioned sort of in the pathophysiology about IL-4. What is it, dupilumab, or one of those, like an IL-4 inhibitor? Has that been tried? Or
there's a bunch of case reports and like small case series, which is definitely growing. There may be some prospective studies abroad that are being undertaken, but yes, there are definitely reports of patients who have IgG4-related disease and some concomitant, atopic derm or something, where they get dupilumab and the IgG4-related disease gets better. Yeah, I don't think we have any, enough robust information there, but yeah, that would be interesting. I don't know quite what to make of it yet, but it would be something to keep an eye on.
Right, because it sounds like atopic diseases are sort of like fairly common in people with IgG4-related disease. So I wonder about the pathophysiology of that. Maybe they share some common.
It's another area that we want to explore, because there is this association, and that's all we can really say right now. It's 30 to 40% of patients have some allergic disease, who have IgG4-related disease have some, and that's much higher than the general population. So, exactly how those two things interface, we don't really know.
Awesome. I mean, it sounds like this is a really exciting time for patients that have IgG4-related disease, and certainly for us rheumatologists who are treating them. Because, back in the day, we really didn't have any options. Now we're hopefully going to get some FDA-approved treatment, and there's a bunch of stuff that's sort of on the pipeline that, we may actually see in clinical practice over the next few years. From your perspective, what are the major unanswered questions that remain regarding, IgG4-related disease and its treatment?
Yeah. Well, there's still so much, about pathogenesis. We talked about, what is the role of the IgG4 molecule. I think there could be creative ways to get at that, given that we now have potential therapeutics that, for instance, just help eliminate IgG production and things like that. So that's an area that would be interesting to investigate. We don't have an animal model, and a large part of that is we don't have an antigen or autoantibody or anything like that to help induce the disease. There have been models proposed. There have been a bunch of studies that have shown autoantibodies, but usually it's like they're detected in maybe 15% of patients, and it hasn't been overwhelming that we really think one of them is the end all be all. And it could just be that there are many different antibodies that form in different patients, different organs, etc. But finding an animal model to help study the disease would be crucial. I think understanding why some patients have progressive organ involvement over time and others, it just stays in one area. That's super hard to study now because we treat everybody and try to prevent that. But we are trying to figure out ways to better understand how to identify patients from older records where before the advent of our ICD-10 code, which came out in October 2023, which is D89.84, and everyone should use it because then it helps us study these patients. But eventually, I think we'll be able to create cohorts looking back in claims data and other things really well and perhaps answer some of these questions. And then again, the damage question, there have been a couple of studies that show, for instance, 60% of patients have organ damage at the time of diagnosis. And a more recent cross-sectional review showed that 92% of patients had long-term damage at that time point. And so are there things we can do to mitigate that with our treatment protocols and things like that? And then for treatment, I think we need to be continuing to think about other targets in addition to just B-cell depletion, what we can do. And then, of course, having an approved therapy will be critical. And then I think other treatments, is there a role for antifibrotic therapy? Obviously, we have those for interstitial lung disease. Are there drugs that target like M2 macrophages or fibroblasts that could be helpful? And then also imaging. I think we rely on various methods depending on the organs involved, but we do use PET CT, FDG PET CT, which I actually find that harder to get approved by insurance sometimes more than treatments. So even if a patient has like known aortitis or other areas where you really kind of want to know if it's active, it can be very challenging to get that approved. But there also may be a role for these newer modalities like what we call FAPI PET, which is looking at fibroblasts activation, given that that plays a major role in the fibrotic component. And there's a number of nice studies, several out of China, that have where patients get within a day of each other a FAPI PET and an FDG PET. And they actually highlight different areas of the disease and even different organs within the body that are involved and potentially different changes over time. So I think there's a lot to learn about imaging and how that can be useful in monitoring disease.
Amazing, Matt. Thank you so much for your time. This has been an awesome conversation and very timely. IgG4-Related Disease Awareness Day is April 4th. And this episode, I believe, is coming out soon after that. And really exciting time to be able to see hopefully the first FDA-approved drug for this condition. And Matt, thank you so much for your time and certainly for your efforts in the clinic taking care of patients and also in your research trying to get these new medications out to the community. So thanks so much for everything you do.
Yeah, no, thank you for highlighting IgG4-related disease on the podcast. It'll be great for the patients and the field. And thanks for having me.
We covered a lot, starting with the clinical spectrum of IgG4-related disease and its often delayed diagnosis, as well as the emerging role of B-cell depletion therapy. We explored the results of the Mitigate trial, as well as some other drugs that are hopefully coming down the pipeline. We looked ahead where the field is going, towards more precision, more access, and hopefully more approved treatment options. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find this and all of our show notes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, may your therapies be targeted, your diagnostics precise, and of course, stay healthy.